Welcome, everyone. Glad to be presenting today Tardive Dyskinesia 360, Achieving and Maintaining Improved Quality of Life in Patients with Tardive Dyskinesia. So with me today is Amber Holberg. She is from Gero Psych Associates of Central Texas, of San Antonio, Texas. And we are pleased to have her and honored to have her with us today. And I am an adult child and forensic psychiatrist out of Michigan and Florida, and do a variety of different things that I'll talk a little bit about as we go through some of the slides, but see a variety of patients with severe mental illness with tardive dyskinesias, as well as other movement disorders, as well as doing clinical research in psychiatry, including movement disorders. So let's get started with Ms. Holberg's and my disclosures. As you can see, both are listed on the screen, and we also have the program information that you can see as well on the screen. And today's program is supported by educational grants from Neurocrine Biosciences and Teva Pharmaceuticals. So let's talk a bit about the consequences of untreated tardive dyskinesia on quality of life in patients taking antipsychotic medications. We'll look at the clinical indications for and clinical benefits of administering the AIMS exam, that I'm sure after this program we will all be doing on a regular basis. And we will incorporate currently available data on the long-term efficacy and safety of VMAT2 inhibitors for the treatment of TD in clinical practice, and we'll look at those clinical trials, including safety and benefits. So an overview, I'm not going to read this to you, but you can see we're going to go through definition and course of TD, all the way through assessment, treatment, the new modified Delphi guidelines that Amber will speak to you about, and then we will conclude. Is everybody ready to go? All right. So definition and course of tardive dyskinesia. Well, we know from the word tardive dyskinesia that tardive, meaning appearing late. So it's generally not an adverse event that occurs right away. The word late makes it a bit difficult necessarily to always determine what's tardive dyskinesia. And remember, this is typically emerging after, on your slide it says long-term use, but it's basically after use of dopamine receptor blocking agents that we frequently refer to as antipsychotic drugs. But it's not only antipsychotic drugs. Anything that's dopamine blocking can have that effect. So there's a variety of GI medications. Most commonly, metoclopramide has been identified, but there's a variety of other prokinetics as well. So tardive appearing late, dyskinesia, which is the distortion or impairment of voluntary movements. The problem is that for so long, we unfortunately didn't identify these abnormal movements once we began using atypical antipsychotics. And we also haven't paid attention to the significant impact, the social stigmatizing effects, how much it impairs functioning, and how much it actually, unfortunately, causes increase in symptoms, either of the core disorder that you're treating, as well as other psychiatric disorders and potentially even medical disorders. So generally, we're talking about involuntary movements. We focus on the face, and the AIMS focuses on the face as well. Remember, 4 out of the 7 movements that we look at are the face. And generally, there's some general wording that we use. The coriform movements, those rapid jerky movements, they can almost look tick-like at times, so you can see where we may get some confusion with other movement disorders. The athetoid movements, the more slow, continual sinus, worm-like movements, as well as the stereotypical rhythmic movements. Rhythmic, but slower and irregular, as opposed to the movements that we see, or the tremor that we see in either drug-induced or Parkinson's disorder. Generally, we see these symptoms developing after exposure to a neuroleptic medication. Neuroleptic meaning dopamine blocking. So if it doesn't have dopamine blocking, we don't necessarily call it tardive dyskinesia. We may see similar movements from other agents that may have an indirect effect on dopamine, but we would call those drug-induced movement disorders versus tardive dyskinesia. Generally within 4 weeks of withdrawal from a medication or while you're on the medication. Remember, after early withdrawal, we call that a withdrawal dyskinesia. Once those movements have persisted, generally for a month or 2, we just call it tardive dyskinesia, even though it occurred during the withdrawal of the medication. And then there's, in the definition, right now we're talking about the DSM, we talk about a 3-month duration. It doesn't mean if someone's had exposure for 2 months, then you wait for a month before you call it tardive dyskinesia. Remember, these are guidelines. And although it's generally thought of at least 3 months or 1 month for those greater than 60, it can really occur at any time. So the theory is that a patient starts on a dopamine blocking agent, and as you block the receptors, you potentially can increase either the number of receptors or the sensitivity to the receptors that can lead to abnormal movements. We can see that within the matter of months, or it can be a matter of years. Or when we stop the medication, remember, dopamine can also suppress the movement. So whatever suppresses the movements can also induce the movements. So as you start reducing the dose of an antipsychotic, you may see the symptoms present. Or if you increase the dose of the antipsychotic, you may see the symptoms decrease. Unfortunately, the more you suppress the movements, probably for everything other than potentially clozapine, you can also be inducing the movements as long as you're looking at blocking dopamine. Severity can range, but the severity has to be looked at not only what the movements look like, but how significantly are they impacting the functioning of your patient. Functioning just doesn't mean physical functioning like buttoning their clothes or eating, but also the impact from a psychological component, from a social component. There's a variety of areas that we look at when we speak to severity. Unfortunately, this disorder tends to be irreversible, meaning even when you stop the medication, the symptoms may persist. And here you see on the slide, TD can continue in a majority of patients, anywhere from 67, 89%, so there's a fair amount of range. And unfortunately, we don't know which patients will persist or not. So the most significant thing we want to do is identify early, treat early, and continue to monitor. And of course, only use dopamine blocking agents when appropriate. So let's look at some patient perspectives on living with tardive dyskinesia. Here we have a video that'll help us describe that. Let's watch the video.
It makes it more difficult because I have to talk to people and be around people all day. So the people I'm around a lot, I just let them know, because I'm sure people think I'm just being silly or making ugly faces at them. Usually whenever I'm talking to people for a long time and we're looking at each other like we are, they'll be like, "Why are you making the ugly face? Stop that." That's what most people say. Stop making faces. But unfortunately, I can't stop making faces.
Take disability. I can't do massage therapy anymore. I am embarrassed to be outside.
I was raised in a very religious family, and they thought I was demon possessed because of some of those movements.
This all started, and I couldn't get, I had gone to my family doctor. It took me a little while to get into a neurologist, and during that period of time, we had Thanksgiving, and we had my wife's relatives. Well, I'm sitting here like this. I'm kind of watching the football game over here because, that way I didn't have to try to talk to anyone.
It's embarrassing. It's quite frustrating. It's ground my teeth down. I grind them at night, and it has actually changed the look of my face.
I've been a psychotherapist for since 1989, so 28 years. And I worked 25 years side by side as a psychiatrist doing medication management, working in a private practice clinic. So I saw tons of patients, and then I've had a private practice since 1989. However, I retired December 15th because of my tardive dyskinesia. It just is too much to, I can explain more about it, but to sit with the client is the akathisia and the tardive dyskinesia. And I've talked with Dr. Kumar, and it's not just a body thing, it's mind, body, and my body's distracted and I can't. The word is trapped. I feel trapped in my mind and I can't. We have a noble profession and we need to be there for our patients. And I get teary. I am distracted, and my body's distracted, and my mind's distracted, and I can't. be there, and we attune, and there's transference. It's a very important job. And sorry, I don't feel like I'm good at it anymore.
So if you think about what you heard a variety of different type of aspects, from occupational, the person that couldn't act as a therapist, the other person who started, the woman who talked about looking face to face was a nurse, and people were thinking she was making faces at them, to the gentleman that was having Thanksgiving dinner with his own family, felt embarrassed. He didn't know what it was. He wanted to isolate himself. So there's a dramatic, significant effect on patients that go well beyond when we just identify the movements. And that's what we have to talk to patients about. And obviously, the earlier we address these issues, hopefully they have less impact on patients' lives. Let's look at some of the risk factors for tardive dyskinesia. So many studies looking at a meta-analysis, this comes out of the Carbon study. John Kane was also part of the study, and Christoph Correll in Journal of Clinical Psychiatry. I would recommend that all of you, if you get a chance, to take a look at this article, because 41 studies looking at over 11,000 patients, average age 42.8, 2/3 male, the majority having schizophrenia or schizophrenia spectrum. When we look at TD prevalence, 25.3%, what do we know from these meta-analysis? We know that clearly first-generation antipsychotics has a greater risk of TD, right? So here we look at second generation, 20.7%. When we look at first generation, 30%. Now you might be thinking, oh, is there just a 10% different? This second generation were patients that were also exposed to first generation antipsychotics. So you can make a difference potentially by having first generation antipsychotic patients switch to second generation. That doesn't mean that it's going to relieve the risk of TD, because we still see a significant amount of TD, or that it's going to resolve for a patient that has TD. But there's generally a lower risk, but the risk doesn't go away. And in fact, unfortunately, even though the risk is lowered, we use second generation antipsychotic much more commonly than we did in the past. Many more indications, from younger ages to older ages. So unfortunately, the number of patients we see with TD may actually go up, although the prevalence or incidence may be decreased. So what if we look at prevalence overall for patients in second generation and first generation? So lower TD prevalence of SGA relative to first generation antipsychotics. And what if we look at one class compared to another? So if we're looking at overall second generation versus first generation, a risk ratio. So if the risk ratio is less than 1, it's obviously greater for the second of the choice. So we can reduce the risk with second generation antipsychotics. And we can even reduce that risk with second generation and first generation versus first generation alone. So what I told you was, if someone was on a first generation and switched to a second generation, there's data to support that you can lower that risk. Where is the risk the lowest? When you have the chance to have patients only treated with second generation antipsychotics. So if you have a patient that's already been treated with a first generation, obviously you lost that opportunity. But if you're starting a patient new, the benefit is to start with second generation antipsychotics and hopefully maintain them on only second generation antipsychotics. That may not be always possible. Maybe a patient will only respond to a first generation, and that risk of TD may be outweighed by the efficacy you get from the first generation, but you want to demonstrate that as you document your risks and benefits. As a forensic psychiatrist, I've been an expert in a variety of cases that may relate to abnormal movements. And most times, the lawsuit is not related to a patient having TD. It's because, one, informed consent was not provided, monitoring was not provided, and now treatment was not either provided or not offered as part of the treatment for tardive dyskinesia. So here we see patients treated only with second generations without prior, especially lower in these 4 studies. Patients without prior FGA, first generation antipsychotic treatment, 7.2% versus those with 30% if you look at overall incidence in first generation antipsychotics. 57 head-to-head trials looking at randomized controlled trials. So not to spend too much time on this, but there's a difference between first generation and second generation. It doesn't go away. It's still quite prevalent. So first generations, when we look at annualized per year TD incident, 6.5% per year, first generation, 2.6% per year, second generation. I was an expert in a case where a patient developed TD. The doctor said, well, you've been on this drug for 25 years. I doubt it's related to the medicine you're on. You've done so well on this for so long without a problem. It increases per year. That's the opposite, actually, of what occurs. You can get increased risk the longer you're on the agent. If we look at overall rate ratio, again, you see 0.35 as your rate ratio. So the number needed to treat with the second generation versus the first generation is only 20, meaning that if I treat 20 patients with a second generation versus a first generation, I may see the lack of generation of tardive dyskinesia. Now, what if we look at among second generation? So first generation versus second generation, we know second generation is lower. That was significantly lower with either olanzapine or aripiprazole versus first generation. It doesn't mean you won't see it with those agents. It may be seen less. Olanzapine has a variety of other potential risks. So you'd have to weigh those risks and benefits. Aripiprazole, we may see a variety of patients with TD, but remember aripiprazole, the use has been increased significantly, especially after it was indicated for the use of adjunct treatment of depression. These are non-clozapine comparisons because clozapine is thought to potentially have a lower risk and may not exacerbate, although there are case reports even with clozapine. What if we look at second generation versus second generation? There was an olanzapine advantage again compared to non-clozapine second generation antipsychotics. You see the rate ratio, 0.66. The number needed to treat, though, much greater at 100. What about other risk factors? So unfortunately, if you look at these risk factors, what do you think about? My patients with schizophrenia. So what are risk factors? And we can look at the odds ratio, getting close to 2, tobacco use, hypertension, obesity, diabetes. Are any of these things can we control? Maybe so. We can maybe really speak to our patients more assertively about, can we decrease tobacco use? That's a pretty tough road in patients with schizophrenia. What happens when patients are overweight? They're not just overweight, they develop hypertension, obesity, diabetes, all significant risk factors, as you can see, for tardive dyskinesia, if you look at the odds ratio. Drug abuse. It's important that we aggressively address drug abuse in our patients, all patients overall, but a significantly high risk of drug and alcohol abuse with our patients with schizophrenia, and clearly there's an increased risk of TD. So cardiometabolic dysregulation, I'll often looked at as metabolic syndrome, substance misuse, both tobacco and other drugs. So let's look at other risk factors. Age. We know even in the definition of TD, 3 months exposure, maybe 1 month in elderly. So elderly not only see TD earlier, it's often maybe more severe. Diagnosis of schizophrenia in itself. Diagnosis of schizophrenia certainly speaks to the use of antipsychotic medications. Dosage, higher dose, longer duration, comorbid bipolar disorders. And what about those patients that develop drug-induced Parkinsonism? Overall, the Parkinsonism syndrome, looking at bradykinesia and tremors, increases the risk significantly for TD. We want to avoid drug-induced Parkinsonism, and the use of anticholinergics can increase the risk and exacerbate TD. So from a risk-benefit ratio, we'd like to use a second-generation antipsychotic, and hopefully not one that would require the use of an anticholinergic agent. Myoclonus, also increasing the risk. You can see hazard ratios, 2.33, more than twice the risk than without myoclonus. Let's look at the impact of TD and functioning and quality of life. And here we see social withdrawal. So here we're going to look at patients with TD and without TD. So what do we see? We see in the non-TD group, social withdrawal significantly less. We heard that from our patients. What did they tell us? I'm embarrassed. I can't go out in public. I can't function in public. I can't be with my family. Social withdrawal, as you can see, p-value 0.001, significantly statistically more significant with patients with TD. What about mental and physical functioning? What we speak to our patients about. The mental component, significantly impaired in those with TD. You can see that they function better if they don't have TD, non-TD versus TD. What else? The physical component and overall physical functioning, as well as quality of life. Quality of life is overall impaired when you have TD, and it makes sense, right? If you have these variety of movements that impair your social functioning, your psychological functioning, and your physical functioning, you're going to have a significant impact on your quality of life that's well described, not only by our patients, but in clinical trials and in studies that actually look at this. How does it play a role for meeting people or getting a job? This is really a well-done study looking at patients with TD and without TD. You're going to look at 1,200 patients watched with TD and 1,200 watched without TD. How would that affect you if you were watching a person that you're thinking about hiring, right? I'd be interested in learning more about this candidate. There's a lot in there, but let's look at the strongly disagree and the strongly agree. Without TD, much greater agreement about learning about this candidate. With TD, less agreement. Strongly disagreeing, same factor. I'd be willing to suggest that others in my company should interview this candidate. Much stronger disagree for those with TD, much stronger agree with those without TD. How about just something that doesn't have anything to do with movements? It shouldn't, just the way they're dressed. Candidate was dressed appropriately, much closer, right? 5 to 4 are strongly disagree, 20 to 19. So more objective measures can be looked at, hopefully a bit closer and equally. I think the candidate would be suitable for client-facing jobs. Is the person suitable to face clients? Look at strongly disagree. 17 strongly disagree, percentage disagreeing, 17% strongly disagreeing for those patients with TD versus 2% without TD. And then you can see a similar numbers with regards to strongly agree. I think this candidate would be suitable to stick them in the back office. Obviously, where other people aren't going to see these movements, and that's what patients do. They hide from others seeing the movements, but this is now seen by others that are viewing the patients. What about looking at dating when you meet someone with TD? I'd be interested in meeting him or her in person for a coffee or a drink. Disagree, strongly disagree for those with TD, and you see the difference also with strongly agree. Less interested in meeting those with TD, unfortunately. He or she is well dressed, again, should be a bit closer, objectively. I would like to continue talking to him or her. Strongly disagree for those with TD, 19% versus 6% without TD. So we can see this trend, as you can see on the slide. Do I find them attractive? Do I want to meet them? Do I want to be more involved with this person? Unfortunately, TD does create a negative impression on others, and patients are well aware of that. So let's look at identifying and assessing tardive dyskinesia with the aims. And I think that we're going to turn over to Amber now to help us go along the aims. Amber, can you take it away for us?
Sure will. So let's take a little bit closer look about the abnormal involuntary movement scale and what it actually examines. So like Dr. Jackson said, there's 7 body regions that we look at. And of course, 4 of them pay really close attention to the facial region. About 80% of tardive dyskinesia symptoms do occur in the facial region. So again, this is the reason why the abnormal involuntary movement scale focuses on these areas. So again, when you're looking at the face, the first one is going to be muscles of facial expression. So again, looking at those muscles around the eyes and up into the nasal passage area. Also looking at the lips and perioral region. So again, focusing strictly on the lips and then that perioral region to kind of rule out to make sure you're not seeing a tremor that might be associated with drug-induced Parkinsonism disease. The tongue, again, making sure you take really close look at the tongue, both doing activation maneuvers, making sure that you see how severely the tongue moves, if it does or doesn't. And then also the jaw area. So looking down into that lower jaw all the way up into that cheekbone region. You're also going to evaluate the upper extremities. So when you look at the upper extremities, you're going to evaluate that which is right above the elbow down through the fingertips. You're also going to look at the trunk, neck, shoulders, and hip region. And then also the lower extremity, which examines right above the knee all the way through the toes. This is what the AIMS looks like. And again, it's the standard of care and how we identify tardive dyskinesia movements. Again, you can see what I talked about in the other slide in those first 7 questions. And again, you want to make sure that you evaluate these each separately, because again, each one needs to be giving its own weight. Again, it's graded on a Likert scale, so 0 being not present or absent, all the way to 4 being severe. So when you're looking at grading areas 1 through 7, the lowest score a patient could obtain is 0, or the highest score a patient can obtain on an AIMS would be a 28. 8, 9, and 10 are questions that look at global judgment. So again, these are going to look at how severe is the movement and also how much does it impact the patient. So 8 will ask about the severity of the abnormal movement. So wherever the highest score is in 1 through 7, that will be your score for number 8. So an example is if you look through 1 through 7 and maybe in the tongue region, you gave that person a score of a 3. When you go to number 8, the severity of abnormal movement would be a 3. 9 is incapacitation due to movement, and I look at pretty much quality of life issues. So how much are they able to do for themselves? Their ADL functioning. Are they able to eat, drink, dress themselves? Are they having trouble swallowing? Any of those quality of life issues. So again, the less problematic it is, it's going to be closer to that 0, 1, 2 mark. The more problematic it is and the more problem it has on their quality of life or their ADL functioning, that's going to be more of a 3 to 4 score. Item 10 focuses mainly just on the patient's report. How does that patient say that their abnormal movements are? So this is a really interesting question to ask because sometimes patients may not be quite aware of their movements and other patients may be hyper aware of their movements. So again, it's really important to assess where does the patient find that awareness or where are they seen on that scale? And then items 11 and 12 is going to focus on dentures and teeth. So if the patient wears dentures or if they have any problems with their teeth or dentures, it's just going to be simple yes, no questions. Of course, we use the AIMS scale to really examine the patient, but that's not what we use to diagnose tardive dyskinesia. In 1982, Schooler-Kane developed 3 diagnostic criteria for tardive dyskinesia that we still use today. So again, one of those criteria that Dr. Jackson has talked about is having that cumulative exposure to the antipsychotics or any dopamine receptor blocking agents. So again, at least a 3-month exposure. Again, remembering in those elderly patients that it's a 1-month exposure. But again, we use this as a guideline. Again, anytime that that patient has had exposure to a dopamine receptor blocking agent, that increases their risk factor. Also, when you're looking at the AIMS, a presence of at least a moderate abnormal involuntary movement in 1 or more body area or a mild movement in 2 or more body areas. So what does that mean? So when you're looking at AIMS and you're identifying movement within those 7 areas, when we're using the AIMS scoring, that if a patient gets at least a 3 in 1 of those 7 areas, that's also indicative that they probably have tardive dyskinesia. Or they have mild movement, which is a score of a 2 in 2 or more of those 7 areas. And again, we always have to make sure that we're mindful that they have an absence of other conditions that might produce involuntary movement. So again, making sure we rule out drug-induced Parkinsonism or other movement type disorders. Again, when we're doing the AIMS examination, we want to make sure that we do a few things before and during the examination. So one is the type of chair that you use for this exam. It's really important that we select one that's hard and firm and that does not have any arms. The reason why is because if we put a patient in a chair that's comfortable or that has arms with them, they're going to put their arms on top of the chair, and what's going to happen is it's going to restrict movement. So it's really important that we select that right type of chair to do our AIMS exam. We also want to ask the patient if they have anything in their mouth, because again, some patients know they have movement. So they might stick a piece of gum, or they might stick candy, or they might put something in their mouth. And so again, you want to make sure that we ask the patients to remove these things if they're in their mouth. We also want to ask the patient about the condition of their teeth. Because again, if they're wearing dentures that are poorly fitted or they have problems with their teeth, we want to make sure that we ask them about this and that we ask them if they have any bothersome problems with their teeth or with their denture currently. We also want to ask whether the patient notices any movement in his or her mouth. Also, we want to ask about all the other areas, all those other 7 areas that we're addressing. So do you notice any movement in your face, any movements in your hand, your feet, your trunk area? You know, and if yes, we want to make sure we ask the patient to describe them and to indicate how are they bothering them and to what extent do they impair their functioning or their quality of life. Now let's take a closer look at how to do the AIMS examination.
My first question for you is just to check to see, do you have anything in your mouth right now like gum or candy? Nothing in your mouth. Okay, very good. Do you have any problems with your teeth right now? Any sores, loose teeth, any problems whatsoever?
No.
Okay, and do you have your own teeth or do you wear dentures?
I have my own teeth.
You have your own teeth. So again, no problems with your teeth at all. Have you noticed at any point in time recently any movements in your face, around your mouth, around your hands, or in your feet? Have you noticed any movements at all or disturbances in those areas?
No,
No, nothing at all?
it's my face.
Just, okay, well, tell me a little bit. What do you notice in your face?
My mouth.
In your mouth? Does it move sometimes when you don't want it to?
Yes.
Okay. Does it prevent you from being able to do anything?
Yes.
Okay. Can you give me an example of something it might prevent you from doing?
Talk.
Difficulty talking? Okay. Very good. And I understand it. Is it something that bothers you or prevents you from wanting to do things?
Yes.
Okay. All right. Now, the next thing I'm going to ask you is I would actually like you just to kind of sit like you are right now. Sit up tall, with your hands on your knees. And I'm just going to observe while you're doing that. Okay, so you just relax. Okay. Next, if you would, please, can you just take your hands and let them hang down to your side? Just let them hang. And I'm just going to sit and observe as well. So you just sit and relax. Okay, very good. All right, Fred, the next piece of the exam is actually a part where I'm going to examine some areas around your mouth. If you could please open your mouth and try and keep your tongue in your mouth for me. So open wide and keep your tongue in. Stay in that position for me. Okay, very good. You can relax. And this is also a portion of an exam where I have to do it twice. It's going to ask you to please open your mouth again and try and keep your tongue in your mouth. All right, very good. You can relax. Go ahead and close your mouth and relax. Okay, the next step is if you could please open your mouth and stick your tongue out. So extend your tongue, open wide and extend your tongue and hold it out. Good, go ahead and relax. Okay, let's go ahead and repeat this one more time as well. So open wide and extend your tongue for me. Very good. Okay, you can relax. Okay. The next part of the exam is one in which I'm going to ask you to raise your arms. So if you could please lift your arms like I am. Very good. I want you to raise one hand, preferably this hand to start. Then I'm going to ask you to tap your thumb to your finger repeatedly. So in this hand, can you please tap your thumb and your finger together and keep going all the way through? Show me how quickly and accurately you can do that. Very good. Now you keep doing that while I observe. Very good. You can relax. Put your arms down. Thank you. Now we're going to repeat it on the other side though, so I need you to raise both hands up again, right about here. Raise this hand, bend it. Okay, in that hand, I would also like you to tap your thumb to your fingers again. So keep tapping, there you go. Keep doing that while I observe. Keep tapping. Very good, you can relax. Okay, Fred, for the next part of the exam, I actually need you to stand up for me if you would, please. And if you could just stand in a relaxed manner, and I will make some observations, and you can just stand and stare straight ahead and just relax. Okay, great. Now, the next part, I would like you to actually stick your arms straight out in front of you, both of them, and just kind of let your wrists hang and bring them down just a little bit lower, right like that. And you just stand there for a few seconds. And again, while I make some observations. You're doing great. Good job. Okay, you can put your arms down and relax.
And again, as you can see from the video, that we observe the patient both at rest and then again with activation maneuvers. And you can see this patient from the exam definitely had significant movements of his tongue and also up into the facial regions, even into the neck region. So again, very important that we watch patients also during activation, and that's where you score patients during the AIMS exam. So let's talk a little bit about the diagnostic barriers. So again, really important that we understand some relevant terminology about antipsychotic-induced movement disorders. Again, this is just a wide range of some of the different terminology of movement disorders that we see in psychiatry. So again, one of them being extrapyramidal symptoms. So this is a very common thing in psychiatry that we talk about, but what's important to understand is that this is kind of an overarching definition that includes both acute and tardive symptoms. So it's going to include akathisia, it's going to include bradykinesia, dyskinesia, dystonia, Parkinsonism, and then of course also tremor. So again, when we're considered that these are related to medication use, a lot of times we often refer to these things as extrapyramidal side effects. Again, when we look at akathisia, akathisia is an excessive movement, usually kind of like a fidgeting of the legs, rocking from foot to foot, or just that inability to stand still. And again, this can be observed during our exam. When you look at bradykinesia, this is something that's commonly associated with a Parkinsonism type symptoms, where patients have a very slowness or a slowing of movement. You can see this when they are in motion, or again, when you're activating one side of the body versus the other, one side may be slower than the other. Also dystonia. Dystonia is a very abnormal, prolonged contracture of the muscles of different regions, mainly in the eyes, head, neck. You can also see it in the limbs and the trunk. So again, this is kind of that freezing or kind of that contracted looking piece that happens with the muscle. Neuroleptic induced Parkinsonism. This is a clinical syndrome that's usually classified by Parkinsonism type features. So these are going to be associated with tremor. You're also going to see some muscular rigidity. So patients may feel like they're frozen or stiff in their motion. They can also have some akinesia, which is this difficulty to initiate movement. Or they can also have bradykinesia, again, like I talked about, where they have a slowness of their movement versus one body or the other. And again, the reason why they call this neuroleptic induced is again, because they're induced by dopamine receptor blocking agents. Also postural tremor. This is a fine tremor that can occur during attempts to maintain a posture. So again, they can have these fine tremors that make their posture look unstable, or if they can't stand still for long periods of time. And then lastly, you have tardive dyskinesia, which is what we've been talking about, that involuntary athletoid choreic looking movement that generally is going to affect muscles in the facial region, that upper or lower extremity, and then also into the neck, shoulders, and trunk area. So it is important that we distinguish between tardive dyskinesia and drug-induced Parkinsonism. And again, if you're looking at the different movement disorders, these two often get mischaracterized for each other. So the one way that they're similar is that they both affect dopamine. But again, they affect dopamine in a different way. Drug-induced Parkinsonism actually affects dopamine by reducing the amount of dopamine that you see in the body. So anytime you have a reduced amount of dopamine, you're going to think of a hypokinetic movement disorder. So again, this is going to be associated often when a patient is on a dopamine receptor blocking agent and they've only been on it maybe for a few days or weeks, or maybe recently the dosage has changed. What you're going to see with this disease process is typically a tremor. And it's usually going to be very rhythmic and fast, usually 3 to 6 cycles per second. And it's usually very rhythmic in nature. It also affects one side of the body versus the other. And it's typically going to be seen in the hand, or it will be seen in that perioral region. So right there, either in the center of the mouth or in the corners of the mouth. Typically, this is where you're going to see it, very rhythmic and very synchronous in nature. It's also associated, like I said, with that hypokinetic movement. So that very slowness, bradykinesia in their movement, also very rigid. So again, that kind of inability to get started, and they can also be very rigid when you do what we call cogwheel rigidity, which is where you test the arms by asking them to move their hands up and down, or we do them in kind of a circular motion. You will find that they have a lot of rigidity associated in this area. And it's also important to understand that tardive dyskinesia and drug-induced Parkinsonism can coexist sometimes. Again, these can be very difficult patients. And again, most of the time, movement disorder specialists are needed in order to help with this coexisting drug-induced Parkinsonism and tardive dyskinesia. It also typically resolves when you reduce the dopamine receptor blocking agent. And again, most of the time, if you reduce the dose or even discontinue this medication, it may persist for a few weeks to months, but eventually it will disappear, unlike tardive dyskinesia, that even when the offending agent is removed, patients continue with that movement. Again, this is really important to understand because this increases the risk, of course, with advanced age, and then any presence of any other of those extrapyramidal symptoms that we talked about earlier. Again, this can increase the risk for drug-induced Parkinsonism disorder. So let's talk a little bit about neurobiology and kind of that modulation of tardive dyskinesia. So it's important to understand that there's multiple factors that impact tardive dyskinesia. Like Dr. Jackson talked about, one of those things that can impact tardive dyskinesia is the fact that when we give a patient a dopamine receptor blocking agent like an antipsychotic, it does block the dopamine receptors on the postsynaptic side. Therefore, what happens is we have these D2 receptors that become super sensitive. So anytime we have dopamine receptors that become super sensitive, the body likes to respond. And the way that the body responds is, one, by increasing the activity of dopamine at that VMAT2, so at that synaptic vesicle. Again, it also is going to determine how much of the VMAT2 activity is going to happen at that presynaptic dopamine concentration. So again, most of the time what happens is that the VMAT2 activity is going to have increased amounts of dopamine, and therefore it's going to come down to the synaptic cleft. And what's going to happen is it's going to increase the amount of dopamine that's going to be given to the postsynaptic area, therefore increasing the risk for tardive dyskinesia. So let's talk a little bit about the causes of TD and how VMAT2 inhibitors might help. So again, I talked about that super sensitive D2 receptors on that postsynaptic area. A lot of times what happens is that we block those receptors with dopamine receptor blocking agent drugs like antipsychotics. And therefore what happens is the body responds by increasing the amount of dopamine that's being released into the body. Therefore, in that nigrostriatal pathway, with that increased amount of dopamine that's being released, you're going to have that increased risk of tardive dyskinesia. So what happens is the way that the VMAT2 inhibition works is that what we want to do is we want to try to either stop the amount of dopamine presynaptically, or sometimes even postsynaptically, where we reduce the amount of dopamine that's coming down presynaptically into that postsynaptic cleft. Because we can reduce that VMAT2 vesicle from getting too much dopamine in it and limit the amount of dopamine that's going in the body, we can improve tardive dyskinesia symptoms. So let's look at the management of tardive dyskinesia. Again, it's really important that we understand that there is a paradigm shift in how we treat tardive dyskinesia now. So it is really important to maybe follow this algorithm in how we treat. Again, the first thing we want to make sure is that we have the right indications for antipsychotic medications. Again, making sure we're using FDA-approved treatments. Again, if it is an improved indication, then we want to make sure that we're always assessing for tardive dyskinesia using the abnormal involuntary movement scale. Again, if the patient doesn't have troublesome symptoms, or maybe there's not really anything noticed on the AIM scale, we may continue to observe the patient. But if they do develop troublesome symptoms, or the patient is having impairment in their quality of life or in their social functioning because of these movements, it's important that, one, we first look at dosage evaluation. So we look at the antipsychotic medication and we decide, are they on the lowest effective dosage? Now, again, if they're a treatment-resistant depression patient and maybe they've been on an antipsychotic medication for a long time and they've been stable, we might try to lower that medication to see if we can improve the movement. But for a chronic schizophrenic that maybe is stable on their current dosage, eliminating that dose or lowering that dose may not be possible, because again, we may increase their risk of hospitalization, or maybe this is the only medication out of 20 that's worked for this patient. So in that step, we would have to make sure that we look at considering suppressive agents. So again, it's important to understand that level A, or that first line treatment for improving tardive dyskinesia, is definitely looking at those new generation VMAT2 inhibitors, because again, these are definitely where we want to start. So if we start with one medication, maybe it's not, we optimize the dose and it's not effective for the patient, or maybe it's still troublesome. Please understand that where one may not work, the other one is different enough that you could actually switch to the other VMAT2 inhibitor to see if you could get improvement in symptoms or make it less troublesome. Again, if the patient is still on a VMAT2 inhibitor, we've maximized the dose and they're still not getting good enough treatment, then the next step would be level B, which is using clonazepam or ginkgo biloba. Again, these have been studied. There's still more studies that need to be done, but again, this would be our level B treatment. If the patient still continues with movements and they still continue troublesome, then our level C treatment would include amantadine. And still, if the patient did not get any improvement in this area, or they were still having troublesome movements, then referral to a movement disorder specialist for possible deep brain stimulation would be necessary or warranted. One of the treatments that we used to use to manage tardive dyskinesia was the use of anticholinergic medications like Benztropine. So it's really important to understand that patients that are on Benztropine may have an extra significant risk factor for tardive dyskinesia. We actually look at this retrospective study done by Karoff. It was 7,985 veterans taking antipsychotic medications. They looked at quite a few different things. One, they looked at demographics. They looked at different comorbidities, some of those that Dr. Jackson talked about earlier, and then also treatment. So they even included antipsychotics, and then they looked at Benztropine. And what we saw within this study is that patients that use Benztropine had the highest risk of tardive dyskinesia, even comparison to other treatment agents and other comorbidities. So again, it's really important to understand that if patients are on anticholinergic medications like Benztropine and they have tardive dyskinesia, we want to make sure that we get patients off this medication or minimize its use. It's important to understand some of the new modern management of tardive dyskinesia. So again, talked about that level A, using those dopamine depleting drugs like Deutetrabenazine or Valbenazine. Again, there's also been some studies going into using chemodenervation with using Botox or botulinum toxin injections. And this usually works very well in patients that get dystonia or some of those other tardive type symptoms. And then also looking at deep brain stimulation. Remember, that was one of those lower levels where we would refer patients to movement disorder specialists to see if patients' treatment with some of these other agents, if they're not effective, or the patient still continues with troublesome movement, that deep brain stimulation might be necessary in order to get optimal treatment and control of their movements. And now I'm going to turn the presentation back to Dr. Jackson.
Thank you so much, Amber. And we're going to look at the receptor pharmacology with regards to Valbenazine and Deutetrabenazine. So here we look at dosing of Deutetrabenazine and Valbenazine with regards to receptor occupancy. This is looking at the VMAT2 receptor. And we can see increasing levels, 6 milligrams through 48 milligrams of Deutetrabenazine, and the doses of Valbenazine, 40 and 80 milligrams, as well as the steady state plasma concentrations that you can see at Valbenazine and Deutetrabenazine. We're going to look at the therapeutic doses that you can see. Net occupancy of VMAT2 by the active metabolites of both compounds is comparable. So let's start off looking at tetrabenazine, where deuterium, a natural occurring stable non-radioactive non-toxic isotope of hydrogen, is going to replace the hydrogen. So here we see tetrabenazine and the structure, and then we're going to take those methyl groups, the hydrogen groups, and we're going to switch to deuterium, a heavier version of hydrogen, and we're going to increase those bonds. So it's going to be a bit tighter, and we have no difference in moving towards the active metabolites through hepatic carbonyl reductase, but what we're going to do is slow the mechanism through 2D6 to the inactive metabolites. That's going to allow us to decrease the dose, but maintain efficacy as we look at the treatment of tardive dyskinesia. So we can half the dose, give twice a day because we're going to increase the half-life, and that looks to how we're going to treat patients with TB with deutetrabenazine. See, we can see on the plasma concentrations that deutetrabenazine, we can chop off those peak levels, but maintain the area under the curve over the time period. So let's look at valbenazine. So here we're going to look at valbenazine and tetrabenazine metabolism. For tetrabenazine, you can see through carbonyl reductase, we see the 4 metabolites. With valbenazine given through a prodrug and hydrolysis and monooxidation, you can see the active metabolite. What does that mean? That we have differences with regards to receptor binding. So if we look at valbenazine, we now have a binding profile of the major metabolites that is only really going to speak to one of the metabolites. So valbenazine is going to now bind only at significant levels at the VMAT2. So remember here, the lower the number, the more potently you bind. So 4.2 at VMAT2, greater than 1,000, no significant binding. The other metabolites, the most significant binding is where you really may see that as a number of 6 at the 5-HT7. 5-HT7 may play a role with regards to cognition, anxiety, and or mood, and you may have some binding with the other metabolites. So limited off-target receptor binding, longer half-life allows Q-day dosing with valbenazine versus tetrabenazine, which is often given 3 times a day, and deutetrabenazine, which is given twice a day. So let's look at some of the clinical trials in tardive dyskinesia. Here we look at deutetrabenazine, 12, 24, and 36 milligrams. We see a change over the 12 weeks with a decrease in AIMS score. So we're looking at AIMS baseline to endpoint with a drop overall of about 3 points at the 24 and 36 milligrams. So what was thought to be clinically significant doses for deutetrabenazine was 3.2 and 3.3 change in the AIMS, or 24 and 36 milligrams. When we look at adverse events, we see the adverse events most significant related to deutetrabenazine. That means at least 2% and greater than placebo. We see overall nasopharyngitis, 4% versus 2%, 4% deutetrabenazine, 2% placebo. And we see the numbers for insomnia, 4% deutetrabenazine, 1% for placebo. Something like somnolence, you actually see somnolence less than placebo. We often look at somnolence as a potential adverse event of VMAT2 inhibitors, and we should talk to patients about that. But in the clinical trials, it was actually lower in drug than placebo. Here we look at valbenazine change on the AIMS. Again, we see significant reduction in the 40 and 80 milligram range, with the most significant range, which is thought to be the therapeutic dose of valbenazine, 80 milligrams, and a drop again similar as what we saw previously, 3.2. Here we look at adverse events for valbenazine versus placebo. Here we look at somnolence, about twice of placebo, 10.9. We see other significant adverse events on the slide, balance disorders, fall, gait, or disturbance or dizziness, about twice the rate of placebo, 4.1 to 2.2. And then we see akathisia 2.7 versus 0.5. Overall, what we see here is a variety of these studies and the overall change that's similar between deutetrabenazine and valbenazine. Let's look at long-term therapy data. Here we see long-term data for deutetrabenazine. We see that out to 110 weeks. There's actually trials even longer than this at this point, but we see a nice reduction throughout the course. These are patients both that were in the trial were now on Deutetrabenazine and continued on Deutetrabenazine, or previously on placebo and then switched to Deutetrabenazine for the long-term open label trial. So 2 years open label, so there's not a placebo. And then we see both clinician and patient rating overall improvement, or CGI or PGI, clinician and patient rated, continues to be very much improved. And you can see the numbers of the majority being either much improved or very much improved. And here we look at the long-term data for Valbenazine. Again, continued treatment throughout 48 weeks and then a washout. So once patients go off drug, their movements again increase close to baseline. And then we see the overall improvement, very much or much improved, similar with both the clinicians and patients rating that improvement. Potential challenges for VMAT2 therapy and potential solutions. So both generally have relatively low rates for somnolence, mild to moderate. We actually saw that in Tetrabanazine. The rate was lower in drug than placebo, but we want to caution patients regards to this when they start treatment. If there is some sedation, you may give a greater dose in the evening than in the morning. You may have to lower the dose lower than what is typically given on label till you get them to have some tolerance, as you can see here on the screen. And that can be similar to what we do with other adverse events. Can have the risk of drug-induced Parkinsonism as we try to increase the rate of the VMAT2 inhibitor, lowers dopamine, you can see adverse events. We're not trying to get patients to zero movements. We're trying to improve overall physical abilities, physical functioning, decrease the impact, and look at decreasing movements, how generally that leads to decreasing the impact. But the idea is the risk and benefit. So you want to look at dosing. And here you can see options that you can look at if you do see some drug-induced Parkinsonism along the way. Patients often have lack of awareness, so we want to make sure to look at their ability to pay attention to their symptoms, and we may have to bring that out for them. More issues with regards to lack of awareness. So overall, we see Deutetrabenazine and Valbenazine can reduce abnormal movements, which can lead improvement to the impact of the illness. Both are well tolerated and effective. And the big bonus is that you can now continue to treat the underlying psychiatric disorder. They remain on their antipsychotic therapy while you start and titrate as tolerated the treatment, which is what we just looked at, Deutetrabenazine and Valbenazine. We need to customize treatment to each individual patient. So you're going to look at the tolerability and safety. With Deutetrabenazine, it's twice-a-day dosing, and you can titrate your dosing. Valbenazine has the benefit of once-a-day dosing, but available in only 40 to 80 milligram doses. No need to change the other medications that are on board, either atypical or typical antipsychotics or antidepressants. We're going to turn it back over to Amber, who's going to summarize some of the Delphi guidelines on tardive dyskinesia. Take it away, Amber.
So let's talk about the new modified Delphi guidelines on tardive dyskinesia. Of course, this was a steering committee of 11 tardive dyskinesia experts, and they met in a format. Again, 60 experts were invited, but only 29 actually agreed to participate. So it was 23 psychiatrists and 6 neurologists. And again, they have lots of experience, 29 years of academic, private, community practice, all had representation in developing these guidelines for tardive dyskinesia. So again, some of the modified Delphi guidelines are which patients should we worry about? So again, looking at some of these patient characteristics. So again, all patients currently taking any medication that's a dopamine receptor blocking agent, so that includes antipsychotics and also some of the prokinetics like metoclopramide, they should be screened for tardive dyskinesia. Again, the following patients or treatment attributes had the highest risk of tardive dyskinesia development. So again, making sure if they're on current or recent treatment with one of those first generation antipsychotic medications. Also age. So again, those that are 65 and older are at an increased risk for developing tardive dyskinesia. Also, that they have longer cumulative exposure to antipsychotic medications. Maybe they started on a first generation antipsychotic and then switched over to a second generation antipsychotic, but the length of time they remained on this was 20, 30 years. That cumulative exposure does also increase their risk factors. And then also if they've had any kind of acute extrapyramidal symptoms, like Parkinsonism or drug-induced Parkinsonism, symptoms also increase their risk factors for tardive dyskinesia. Again, in these new modified Delphi guidelines, we want to make sure that we focus on screening. So again, we talked about that AIMS being the standard structure assessment to really monitor for severity of that tardive dyskinesia symptoms. But of course, it's important that we know at every single time you see these patients, you may not be able to do a complete AIMS. So make sure you're doing some kind of semi-structured assessment and that you can modify or use in your clinical practice to screen for tardive dyskinesia. So some of these things might be to include patient recognition of either current or recent abnormal movements, asking them about, do you notice about having movements of your face, your upper or lower extremities, or into your neck or shoulder region. Also, visual observation of psychomotor abnormalities. This can be seen on our mental status exam. Every time we see a patient, we do a mental status exam. So this should be part of what we're assessing for to see, do we notice any movements while we're talking to our patient? Or maybe while they're talking about something stressful, that it's bringing out some movements that we're noticing. Also asking caregivers to report recent or current abnormal movements. If the patient is not very insightful or they're not able to recognize that they have these movements, maybe asking a caregiver or a family member or a loved one, do they notice these things occurring in the patient? Also, patient report of history of movements or any kind of psychomotor changes. You know, that can include both drug-induced Parkinsonism type movements, also tardive dyskinesia movements. And then also, does the patient complain about these movements causing distress? So does it interfere with their social? Does it also interfere with their quality of life? So again, are they able to physically, have physical functioning, or do they have problems, eating or swallowing or drinking? And that can definitely be problematic for a patient that they might want to bring definitely to your attention at your evaluation. Screening frequency, that's really important to talk about, clinical assessment to screen for tardive dyskinesia that are taking antipsychotic medications or other dopamine receptor blocking agents, regardless of the degree of risk of tardive dyskinesia, should be done at every clinical encounter. So it's really important that we do adopt some type of semi-structured or less frequent structured assessment of looking for movement, whether that includes just talking to our patients at our exam about it, or looking at that during our mental status exam, making sure that we're routinely looking for it and we're routinely screening our patients for this. So treatment approaches, again, according to the modified Delphi guidelines, they want us to include the following strategies and that they should be part of our treatment approach. Again, one, discussing treatment options with our patients and caregivers. Again, like Dr. Jackson said, he was called as an expert witness during one, about tardive dyskinesia. And the main thing is not discussing treatment options with the patients or even monitoring for this. So making sure we're discussing this with our patients or the caregivers, giving them that option is important. You also want to review and consider modifying antipsychotic regimens. Sometimes this can be done and other times this may not be able to be done because it's going to risk the patient having destabilization of their mood or risk of hospitalization. And then again, using on-label FDA treatments with VMAT2 inhibitors. So again, talked a little bit about anticholinergics earlier, but I do want to call some of the things that we talk about here in the modified Delphi guidelines. So again, when you're using anticholinergic medications in a patient with tardive dyskinesia, especially if it's part of their TD management, you want to consider modifying these anticholinergic agents. Again, maybe definitely reducing the dose or even tapering the patient off. You never want to abruptly discontinue an anticholinergic medication like Benztropine because again, that can cause more problems for the patient. So again, consider reducing the dose over time or putting them on a taper schedule of how to get the patients off these medications. Again, in considering whether to modify the anticholinergic regimens as part of their tardive dyskinesia management, we also want to make sure we look at the presence of acute extrapyramidal side effects, especially dystonia, because again, it must be considered because sometimes patients may be on anticholinergic medications for other indications, sometimes even outside of their tardive dyskinesia. Some patients may be on anticholinergic medications because they have tardive dyskinesia and drug-induced Parkinsonism present in the same patient. So again, making sure that we're looking at this, taking patients off where necessary, but not abruptly discontinuing. Also want to talk about the VMAT2 inhibitors and tardive dyskinesia. So making sure that we consider it when we prescribe VMAT2 inhibitors, that again, we want to make sure that it's an overall integrated pharmacologic treatment plan. that we're making sure that we're talking to our patients, the caregivers, and that we're actually getting them on board and talking to them about our treatment plan for what we hope to accomplish by adding a VMAT2 inhibitor to the patient's regimen. It also needs to, you need to look at the patient's condition and their needs. You need to take that into effect when you're determining what type of VMAT2 inhibitor you're going to use. You also need to document if the patient and the caregiver requests or agrees to this type of treatment option. And then again, you also want to talk about the response to antipsychotic maintenance or modification if that's something that's necessary or something that we're able to do for our patients. We also want to make sure that we're assessing tolerability, safety, efficacy, ease of use. We want to take that all into consideration when we're determining what type of VMAT2 inhibitor we want to use for our patient, because again, all of these things are important. You know, how tolerable is it? Is the patient compliant? You know, are they able, is the ease of use easy? And we want to pick that right VMAT2 inhibitor for our patients. And then also if a VMAT2 inhibitor is ineffective or it's not tolerated, maybe you started with one or it was declined by the patient, the next step is again to, like I said, switch to another VMAT2 inhibitor before using other less evidence-based agents like I talked about earlier. So let's conclude, let's wrap it up here and conclude the slide. So again, let's talk about what we've learned today. So again, tardive dyskinesia is often forgotten as the problem in the age of atypical antipsychotics, but again, it's still a very real challenge and something we need to be mindful of every day that we see our patients. Again, the understanding of the risks and characteristics of tardive dyskinesia have evolved. And again, more data and knowledge has accumulated, but again, more research and more needs to be done in this arena. The consequences of tardive dyskinesia on a person's life are considerable, especially when you look at social, psychiatric, functional. It can definitely impact a patient's life, and it can be very large. It's important that we're screening proactively, routinely, and that we're really looking for tardive dyskinesia in our patients, especially those that are being treated with an atypical or typical antipsychotic. Again, innovative alterations of tetrabenazine, such as Deutetrabenazine and Valbenazine, are expected to better serve patients' needs, especially if they have tardive dyskinesia and need treatment. Treatment planning should include assessment of adherence and addressing barriers to adherence to effective treatments for tardive dyskinesia. Also, significant and promising research is occurring, including activity on control of tardive symptoms with multiple VMAT2 inhibitors. So it behooves us as clinicians to really make sure we're staying up to date on the new developments in this field. We also want to make sure we're improving functionality in tardive dyskinesia patients. That's a big goal of our treatment, not just looking at that score on the paper, but really improving the overall quality of life and the physical and emotional impairments that are caused by tardive dyskinesia. And with that, that concludes our presentation. So thank you for being here today and allowing me and Dr. Jackson to provide this education to you.